Okay, let me invite the first speaker, Dr.Ruvan Ekanayaka, Senior Consultant Cardiologist, MD, FRCP. I think we don't need much information about Dr. Ruvan Ekanayaka. Had published many articles, had done many research, and senior consultant who pioneered the cardiology unit at Gaul, and had contributed to the country many research and produced many cardiologists, and teach many doctors. And so I would like to invite Dr. Ruvan Ekanayaka to start the first lecture, today's webinar.
Thank you very much, Dr. Vasanthi, and a very good evening to all of you and to all our webinar participants from Gaul, Jaffna and Kandy. So we are having this webinar on coronary syndromes, and the coronary syndromes are divided into two, the chronic and the acute. I will speak on the chronic, and Dr. Stanley Amarasekara will speak on the acute coronary syndromes. Right, so to proceed, this will be based on the 2019 guidelines of the ESC, which published a new guideline on the management on chronic syndromes, coronary syndromes. Now, when you take the spectrum of myocardial ischemia, we have a whole spectrum ranging from stable angina to ST elevation myocardial infarction and sudden cardiac death. And you must remember that of all the syndromes that are going on here, they are symptomatic. This entire spectrum of acute myocardial ischemia goes on also at silent ischemia, so that you have silent stable angina and a silent MI where the symptoms are not seen. Now, if you take the spectrum of myocardial ischemia and you take the pathophysiology, you find that angiographic thrombosis is found in very little in non-ST elevation myocardial infarction, and it is over 90% in ST segment elevation myocardial infarction. If you do an angioscopy looking at the coronary artery itself, you find no clots in non-ST elevation myocardial infarction and stable angina, where you find a white clot in non-ST elevation myocardial infarction, that is unstable angina, and a red clot in ST elevation myocardial infarction. This is fibrin rich, into which matrix the red cells have got in, and therefore the clot is red. The white clot is rich in platelets. Now, this pathophysiological basis is important for us, because when it comes to treatment, it is based on the pathophysiological findings. You find also that in the spectrum of myocardial ischemia, the activated platelet levels are changing. In the stable syndromes, it is only 0 to 5% of platelets are activated, whereas in the acute coronary syndromes, 70 to 80% of platelets are in the activated form. Now, you have a whole host of vulnerable plaques which are causing occlusion to the coronary arteries. The atherosis is there, the thrombosis is there, and the calcification is there, which will be later important to us when we come to the diagnosis of chronic coronary syndromes. So, we all know the features of the vulnerable plaque. It is the vulnerable plaque without significant luminal narrowing, that is, the lumina is narrowed only to 20 to 30%, 40% sometimes, inadequate to give rise to ischemia or angina symptoms. Nevertheless, these are the dangerous plaques with high infiltration of monocytes, the thin fibrous cap, and rich in foam cells, which will rupture. And unless you have rupture, erosion and distortion of this plaque, no acute thrombus occurs, and then we end up with chronic syndromes only. Now, you have the normal coronary artery, and for atherosclerosis to build up, you will take decades, 10, 20, 30, 40 years for atherosclerosis to build up. But these will be stable syndromes. For it to become symptomatic atherosclerosis, where a thrombus has occurred, it takes only a few minutes. So, thrombosis occurs on a ruptured or eroded plaque within a few minutes without warning, and then you have the acute coronary syndromes going on. Now, coronary artery disease is a pathological process characterized by atherosclerotic plaque accumulation in the epicardial arteries, obstructive and non-obstructive. Both are ischemic heart disease. The process can be modified, and this is important, by lifestyle adjustments, pharmacological therapies and invasive interventions designed to achieve disease stabilization or regression. So you can modify the process. The dynamic nature of the coronary artery disease process results in various clinical syndromes, as I have said, and they are divided into the acute coronary syndromes and the chronic coronary syndromes. Now the chronic coronary syndromes now have been divided into 6 groups. There are 6 types of coronary syndromes. First and foremost, we have the classical stable angina with suspected coronary artery disease, stable angina symptoms, and the angina can be a surrogate where there is only dyspnea. Or you can have patients with new onset heart failure or LV dysfunction, where we only suspect that there is coronary artery disease. There is no pain, but the LV dysfunction is there. The LV dysfunction is there. So here we are talking about symptoms. Here we are talking about LV dysfunction on echocardiography. Then we have 3 and 4 syndromes, which are following acute coronary syndrome event. Type 3 is where there is a patient with acute coronary syndrome within 1 year. Now after 6 weeks, the plaque has stabilized, and therefore the acute coronary syndrome has now become a chronic coronary syndrome. Within 1 year, it is type 3. If it is over 1 year, it is called type 4. Why do we make this distinction between type 3 and type 4? Because the natural history of the disease, the MACE and the death rates are different. Fifthly, we have patients with angina, suspected vasospastic or microvascular disease, because the coronary angio or any other form of anatomic imaging indicates that there is no epicardial arterial block. And then we have group 6, where the patient is completely asymptomatic, but somebody has ordered exercise ECG or even a CT coronary angiogram for risk assessment or diagnosis or routine health screen, and you find occlusion or ischemia on exercise ECG, and that constitutes the 6th syndrome in this new classification of coronary syndromes. Now, why do we have 6 syndromes? Because of the different risks for future cardiovascular events, different risks. Here we can have chronic syndromes which are chronic for years. We can have only one acute coronary syndrome. We can have several acute coronary syndromes, and the patient has a very stormy course. So you see the 3 graphs diverging, and you find that the natural history changes according to the patient's tomographical pathophysiological basis. Now the patient with angina and or dyspnea and suspected coronary artery disease, how are we going to make a diagnosis? And the ECS guidelines gives us 6 steps. Step 1, you assess the symptoms and perform a clinical investigation. Clinical, it is examination and history. Step 2, you consider the comorbidities and quality of life. Now this is very important. You just don't make a diagnosis of a coronary syndrome, you put it into the perspective of the totality of the patient's total health. So the comorbidities and the quality of life. Then you go on to the step 3, which is investigation, the ECG, the biochemistry, the X-ray and the echo, etc. And step 4, you do a pre-test probability on the clinical likelihood of coronary artery disease. You don't blunderbuss go and do invasive or non-invasive tests for everybody. A pre-test probability is assessed by the score evaluation. And it is step 5 that where the new recommendations come in. If the clinical likelihood of coronary artery disease is very low, the investigations are different. If the pre-test probability is very high, then the investigation is different. So step 5 is the one that tells us how to investigate. You can have the coronary CTA, you have various other forms of testing which we will talk about, and then you have the invasive coronary angiography. And then finally, you impose appropriate therapy based on the symptoms to prevent future events in a patient. So symptoms and signs. A careful history is the cornerstone of the diagnosis of angina. In fact, Brunel says, if you read Brunel, history taking is the most important investigation in angina. It is possible to achieve a high degree of certainty on a diagnosis based on the history alone. So, in the physical examination, exclude anemia, hypertension, valvular heart disease, hypertrophic cardiomyopathy and arrhythmias, which will be substrates for angina type of pain in the absence of occlusive coronary artery disease. Now, the traditional clinical classification of suspected angina symptoms is a triad: constricting discomfort in the front of the chest, in the neck, jaw, shoulder or arm, point 1. Point 2, precipitated by physical exertion, that is point 2. And point 3, relieved by rest or by nitrates within 5 minutes. If the pain goes off after half an hour of nitrates, you cannot take it as criterion 3. Criterion 3 is where the pain goes off within a very short period of time, usually within less than 5 minutes. Now, if you feel all 3, that is typical angina. If only 2 of these are there, it is atypical angina. And if there is only 1 or none of these criteria, it is non-anginal chest pain. That is how the guideline now classifies the angina symptoms in their guideline. Now, new onset angina, if the angina has occurred within the past 2 to 6 weeks, traditionally we have been teaching that that is acute coronary syndrome because it is an unstable angina. But the new guideline says, if the angina occurs for the first time with heavy exertion, say you are doing some wheelbarrowing or gardening or climbing 6 flights of stairs and you get the angina for the first time, by the old definitions it is unstable angina, by the new definitions they say it falls under the definition of chronic coronary syndrome. So, that is an important symptomatic analysis which has been changed. Now, question the patient on bodily location, setting, chronology, quantity, quality, aggravating and relieving factors. Now, the pain that you get in ischemic heart disease is distributed in what is called the 6 dermatome band, T1 to T6, which is referred pain. And deep visceral pain behind the sternum or in the precordial pain is not specific for cardiac disorders. It comes from the esophagus, from the mediastinum, gallbladder, liver, stomach, and therefore the 6 dermatome pain can come from any of these organs which I have mentioned. It is the primary symptom of the entire region supplied by the dermatomes T1 to T6 in the sympathetic chain. Now, it is usually mid-chest. It is not uncommon for pain to originate or even be localized to the epigastrium, neck, jaw, shoulders and arms, rarely between the shoulder bands only. So, the 6th band we have spoken about. Now, the discomfort is usually limited to the chest but radiates simultaneous to the elbow or the wrist. The arm may feel heavy and lifeless, so that you might mistake it for a TIA. Less frequently the pain radiates to both arms or to the right arm or to the jaw and the teeth. Radiation to the left leg is also accepted. Now, in some patients, pain may be confined only to one of these areas without radiating elsewhere. This is called skipped radiation. Whereas the chest patient is there, it is going down the arm, but the intermediate area is spared and you get pain only in the elbow or only at the wrist and you mistake it for arthritis or arthralgia. The skipped radiation, sometimes the joints are missed and the intervening area only is paining. So, this is called skipped radiation. And therefore, we say any pain between the eyebrows and the umbilicus is angina until angina is proven, it is proven otherwise. So, we have the centripetal radiation and the centrifugal. The centripetal is the common one, starting from the chest and going to the arms. Centrifugal in unstable angina, it starts from the arm and goes to the chest. And any type of aching, squeezing, pressure, heaviness and burning can be the features. Aggravating factors are important. Bending, so that we now describe a syndrome of bendopnea, which is also there in heart failure. Squatting, postprandial angina, upper limb exertion more than lower limb exertion. So, you can walk sometimes for 2 to 3 kilometers, no angina. You bend down to brush your shoes or to rub soap on your legs and you have upper limb exertion. Though we have always wondered why, because the lower limb muscle mass is greater, we should have more angina with lower limb exertion, but that is not the way it goes. The upper limb exertion causes more angina than the lower limb exertion. The pathophysiology is important. You can have a dynamic stenosis, microvascular dysfunction or thrombosis in angina. Chronic stable angina is caused by flow limiting coronary artery stenosis. But there is also in chronic stable angina a dynamic component and a microvascular component, and the thrombotic component is very low. In unstable angina, thrombosis dominates, and the dynamic stenosis and the microvascular discomfort are also contributing. In microvascular angina, dynamic stenosis and thrombosis is not there. Now you must remember that anginal pain can have surrogates, which are called angina equivalents. Burning sensation in the epigastrium, feeling of indigestion, desire to burp, desire to defecate with symptoms, undue dyspnea and fatigue, lightheadedness, diaphoresis in the elderly. All this can be angina equivalents which mimic anginal pain, which indicate anginal situation without there being pain. Now the second step is to get the comorbidities. Before any testing is considered, the ESC guideline says one must assess the patient's general health, comorbidities and quality of life. If revascularization is unlikely to be an acceptable option, these are very words from the ESC guideline, testing may be reduced to a clinically indicated minimum and appropriate therapy should be instituted, even if the diagnosis of CAD has not been fully demonstrated. Sometimes you get patients 85 years, 90 years old with an angiogram report. Now it is quite obvious to everybody that this patient with renal failure and cirrhosis is not undergoing any form of major revascularization. Nevertheless, every clinic, 1 or 2 patients we see with comorbidities and general health inappropriate for revascularization, subjected to invasive investigation, which the ESC guideline specifically says do not do. If the patient is clearly non-anginal, then get the gastrointestinal, pulmonary and musculoskeletal cause of pain, but always, even if it is non-anginal, if the patient has come to you, guideline based risk factor modification must be instituted, even though at the present moment it is non-anginal in your clinical assessment. So you do your basic tests, the full blood count, creatinine measurement and a lipid profile, and remember it is recommended that screening for type 2 diabetes mellitus in patients with suspected and established CCS is important with HbA1c and fasting plasma glucose. And an oral glucose tolerance test is added if the HbA1c and fasting plasma glucose results are inconclusive, because this pre-diabetic and diabetic state have to be managed ideally in order to reduce the aggressive nature of the atherosclerosis. Now, if you suspect ischemic heart disease, you do a ECG, but ECG may not catch up the angina, because now the patient has no angina symptoms at that time. Therefore, the ambulatory ECG recording, preferably monitoring in 12 lead, should be considered in patients with suspected vasospastic angina specifically, because this will give us a diagnosis without going into a major invasive investigation. Now, what about exercise ECG, the new guideline? It has inferior diagnostic performance compared with diagnostic imaging tests and has limited power to rule in ischemic heart disease or rule out coronary artery disease. Limited power, that we have to keep in mind. And the randomized clinical trials have compared the effects of the diagnostic strategies based on exercise ECG or an imaging diagnostic test on clinical outcomes. And these studies have shown that the addition of coronary CT angiogram or functional imaging clarifies the diagnosis, potentially reduce the risk of myocardial infarction compared to exercise ECG alone, because you have more courage in intensifying the medical management of these patients. Therefore, the new guidelines recommend the use of an imaging diagnostic test instead of the exercise ECG as the initial test to diagnose obstructive coronary artery disease. We will talk about this a little later. But exercise ECG also has its values. It is useful for the assessment of exercise tolerance, symptoms and arrhythmias, blood pressure response and even risk in selected patients. That is class 1. As an alternative to the non-invasive imaging, it is only 2B. But it is considered in our setup because we have no access to this all the time. There is a stage class 3 recommendation where it should not be done also, where it is not recommended for diagnostic purposes in patients with ST segment elevation more than 0.1 volt on the resting ECG or those being treated with digitalis, and exercise ECG cannot be interpreted. Then you do an echocardiogram. What do you look for in the echocardiogram? You look for the alternative causes of angina, say HOCM or severe aortic stenosis maybe. Identification of the region wall motion abnormalities, measurement of the ejection fraction for the risk stratification, and evaluation of diastolic function for your therapy later on. Chest X-ray mainly to eliminate causes of pulmonary disease. Now, even if we talk about this history, see how much of overdiagnosis we can go on the history. If you take people, males for example, 40 to 59 years of age, those with a typical history of angina, only 20 to 32%, one third or so will have obstructive coronary artery disease on imaging techniques. Of course, as you grow older, half of them will have so. If the patient's symptoms are non-anginal, then it is very, very little that the yield is for obstructive coronary artery disease. So, with the symptoms alone, we go to treat, we are of course guilty of over-treating. That is of course true. But then if you go to make a diagnosis of obstructive artery disease, this is also a problem for us for the simple reason that today the patient may not have obstruction, tomorrow the patient might have obstruction, because it is a dynamic process. Therefore, as clinicians we go on the history, but always at the back of the mind, the symptoms are not a real guide to you to keep on increasing your medication. What we should really do is to have intense medical risk factor control. Then we have the pre-test evaluation, probability evaluation, and we use the score, the score of the coronary estimates, coronary artery obstruction estimates on the European low risk chart, but for the Asians they recommend that we use the European high risk chart. So, on that we take the evidence. Now, once you take the pre-test ability, then you come to the penultimate step in the guideline, selecting appropriate testing. In patients in whom revascularization is futile due to comorbidities and overall quality of life, the diagnosis of coronary artery disease can be made clinically and only medical therapy is required. This is the ESC guideline. If the diagnosis of coronary artery disease is unstable, establishing a diagnosis using a non-invasive functional imaging for myocardial ischemia before treatment is reasonable. It is reasonable because of the toxicity of the drugs that we might use. However, if the patient has a high clinical likelihood of coronary artery disease on the score, symptoms, and the patient has symptoms unresponsive to medical therapy, or the patient has typical angina at low level of exercise, you can proceed directly to invasive coronary angiography without further diagnostics testing, and this they say is a reasonable option, and this is what as clinicians we are already doing. If the patient has a high risk of coronary artery disease, say diabetic, strong family history, hyperlipidemia, symptoms are unresponsive to medical therapy, we cannot control the symptoms, and it is typical angina at low levels of exercise, you may proceed to coronary angiography and no one can find fault with you because the ESC guideline now approves that as being very reasonable. In other patients in whom coronary artery disease cannot be excluded by clinical assessment alone, non-invasive diagnostic tests are recommended to establish the diagnosis and assess the event risk. And we have two non-invasive tests. We have the functional non-invasive test and we have the anatomic non-invasive test, the two groups of non-invasive tests. And the functional non-invasive tests are a plethora. ECG changes are there, the wall motion abnormalities are there on the stress CMR or the stress echo, perfusion changes are there in the SPECT scan, the single photon emissions, the positron emission, the PET scans, the myocardial contrast echography or contrast CMR. Ischemia can be provoked by exercise or by pharmacological stressors, either by increased myocardial work, oxygen demand, or the heterogeneity in myocardial perfusion by vasodilatation, because the obstructive coronary arteries and the endothelial dysfunctional coronary arteries will not dilate with our thing, and you find the heterogeneity in the myocardial perfusion. So, these are the functional non-invasive tests that are recommended. Then we have the anatomical non-invasive evaluation, and here there is only one test, that is the CT coronary angiography. Provides high accuracy for the detection of obstructive coronary arteries. However, now the guideline says, if the CT coronary angiogram says there is an obstruction over 90%, then we take it as being positive. But if they say 50 to 90% is the luminal diameter obstruction, the new guideline on the chronic coronary syndromes, because this is upon visual inspection, not necessarily functionally significant. They do not always induce myocardial ischemia. Therefore, the CT coronary angiogram lesion is indicative of high therapy or invasive therapy only if over 90% according to the new guideline. 50 to 90% we have to go in for a functional non-invasive assessment before we decide what to do. Now, why is this stuck? So, therefore, either non-invasive or invasive functional testing is recommended for further evaluation of angiographic stenosis detected by a coronary CT angiography or invasive angiography, unless a very high grade over 90% diabetes stenosis is indicated via invasive angiography. It is known that in patients with extensive coronary artery disease, coronary CTA complemented by CT based FFR. Now, there is a CT based FFR also. It is non-inferior to invasive coronary artery angiography and FFR for decision making and the identification of targets for revascularization if you want to reduce MACE. So, then we have made a diagnosis, and we come to the final step in the ESC diagnosis, assessment of event risk. It is event risk is recommended in every patient being evaluated for suspected CAD or newly diagnosed CAD, and it has major impacts on therapy decisions. Now, how do you decide that? You do exercise ECG and you take the Duke treadmill score, and on the treadmill score you can say the cardiovascular mortality is more than 3% on this treadmill score. That is high risk. If you have done a PET scan, then if more than 10% of the left ventricular myocardium is at risk, it is high risk. In the stress echography or the CMR, if more than 3 out of the 16 segments in that assessment show ischemia, hypokinesia or akinesia, then it is high risk. And in the coronary CT or invasive coronary angiography, 3 vessel disease with proximal stenosis, left main disease or proximal anterior descending disease is high risk. If you do the invasive functional testing, the fractional flow reserve or the instantaneous wave free ratio, if anything less than 8.8, then it is high risk. So, the clinical the interventional cardiologist going through the patient must have in his hand this information which establishes the high event risk group within the chronic coronary syndrome in order to give preference to revascularization. Now, lifestyle recommendations according to the ESC, smoking cessation, you know that, healthy diet, physical exertion, healthy weight, and that is given of less than 25 kilograms per square meter body surface area, and taking medications as prescribed is important in the lifestyle modification. And the healthy diet characteristics, just for interest sake, increase the consumption of fruits and vegetables more than 200 grams each day, 35 to 45 grams of fiber, preferably from whole grains. Moderate consumption of nuts. The walnuts, hazelnuts, pistachios and the almonds are the ones that are recommended. Whether peanuts and cashew nuts will have the same benefit, we do not know, but peanuts also probably, but the established results are with the ones that I mentioned before. Of course, very expensive. 1 to 2 servings of fish per week. There is no need to take whole hosts of fish oil capsules. 1 to 2 servings of fish per week is the recommendation. Limited lean meat, low fat dairy products, and the liquid vegetable oils. Liquid because then they are polyunsaturated. The saturated ones are solid at room temperature, in the fridge door. Saturated fats only less than 10%, and you replace the rest with polyunsaturated fats. Of course, the pure study gave us some more detailed instructions on this. The trans fats are very important. From processed foods, it should be less than 1%, only 6 grams of salt per day, alcohol, and avoid energy dense foods such as sugar sweetened sweet drinks. Now, if you are going to treat these patients, the recommendations have again changed. The new recommendations, they are given 3-4 steps, the first, second, third and fourth step in the selection of drugs for chronic syndromes, and the patient is divided into a patient with high resting heart rate, low resting heart rate, LV dysfunction or heart failure, and a low blood pressure at the resting state. Now we find this whole gamut, the whole spectrum of these patients in our clinical practice. And then when you select the drugs, the recommendations are different. Standard therapy, beta blocker, calcium channel blocker, beta blocker at second line drug, and the fourth step at nicorandil, ranolazine or trimetazidine. Now if the patient's heart rate is high at rest, that is over 80, you give a beta blocker or a non-dihydropyridine calcium channel blocker. And later on you add ivabradine if the heart rate is still not high. Now you all will all know that. If the heart rate is low initially, you can only start on a dihydropyridine calcium channel blocker. You cannot start on anything else, and that is recommended. Amlodipine or felodipine may be started on, and the nitrates. Now the nitrates come only for the low heart rate person, though we give it as first line. I will tell you why we give it. And then you add nicorandil, ranolazine or trimetazidine according to the new guideline. Now if the LV dysfunction is there, nitrates, ivabradine and beta blockers as per treatment for heart failure, and the blood pressure is low, then we have low dose beta blocker, low dose calcium channel blocker, low dose long acting nitrate, and then nicorandil, ranolazine and trimetazidine are elevated from the fourth step into the third step, ivabradine, ranolazine and trimetazidine. Now most of us give nitrates even though there is no good evidence that it relieves, it has mortality benefit. Two reasons why we give it. First and foremost, if there is a vasospastic element with the beta blocker, we can in the natural history, that dynamic component can be treated by the nitrate. Secondly, you give the beta blocker, you block the beta, alpha is overacting, causing vasoconstriction. It is in order to reverse that some of us use these nitrates in clinical practice, although the guideline gives us the long acting nitrate only in the low heart rate category. So this chart is also important. When you are giving the long acting nitrates, a nitrate free or low nitrate interval should be considered to reduce tolerance. So don't give Imdur BD, that is wrong therapy. It can give too many because the low levels are maintained if you give that. Now remember, nicorandil, ranolazine, ivabradine and trimetazidine should be considered as second line treatment to reduce angina frequency, improve exercise tolerance in subjects who cannot tolerate or have contraindications to, or whose symptoms are not adequately controlled by beta blockers, CCBs or nitrates. In subjects with baseline low heart rate and low BP, ranolazine and trimetazidine may be considered as first line drugs to reduce angina frequency and to improve exercise tolerance. In selected patients, a combination of a beta blocker or a calcium channel blocker with the second line drugs, ranolazine, nicorandil, ivabradine, trimetazidine, may be considered for first line treatment according to heart rate, BP and tolerance. So great liberties have been given to the clinician in selecting these drugs depending on the pathophysiological state of the patient. Now, how are we going to prevent? How are we going to, do I have time? 5 minutes and I am finished. Recommendations for event prevention: antithrombotic therapy in patients with chronic coronary syndromes and sinus rhythm. You give aspirin to all patients with previous MI or revascularization. No controversial there. Clopidogrel 75 mg is recommended as an alternative to aspirin in patients with aspirin intolerance. You can give clopidogrel. So can you give clopidogrel monotherapy? According to the new guideline, yes, if there is aspirin intolerance. Clopidogrel 75 mg daily may be considered in preference to aspirin in symptomatic or asymptomatic patients with either peripheral arterial disease, history of ischemic stroke or transient ischemic attack, where clopidogrel might have an edge over aspirin in prevention. Now, you cannot give aspirin in patients without a history of myocardial infarction or revascularization, but has definitive evidence of coronary artery disease, that is 2B, not 1 but 2B, but yes, we give, all of us will give it, but it is allowed by the guideline, but only the recommendation is 2B. If you do not give it, you can find fault, but it is probably better to give it. Adding a second antithrombotic drug to aspirin, that is aspirin plus clopidogrel, for long-term secondary prevention should be considered in patients with high risk of ischemic events without high bleeding risk. So, if the patient is at very high risk of ischemic events, we give aspirin plus clopidogrel. Lot of people omit it now. They omit it on the ground saying that if you have put in a stent, after 1 year you can omit it. But we are not talking about stents here. We are talking about chronic coronary syndromes, and see the guideline. If the risk of a second event of ischemic is high, then we add a second antithrombotic drug. If there is no high bleeding risk. Now see the other recommendation, that is 2A, that is 2A. Adding a second antithrombotic drug to aspirin for long-term secondary prevention may be considered, that is add clopidogrel. Whoever moderately increases, now this says high risk, that is 2A. If it is moderately increased, again it is recommended, but only 2B. But the evidence, level of evidence is very good. Therefore, remember, in aspirin and clopidogrel, don't artificially keep on omitting clopidogrel saying there is no indication, this is all recommended. That is not correct. Even in stented patients, the way to give clopidogrel is now very controversial, but now if recommended following stenting, aspirin is of course established, no doubt about that. Clopidogrel is recommended in addition to aspirin, that is dual antiplatelet therapy for 6 months minimum, following coronary stenting irrespective of stent type, unless there is life-threatening bleeding. If the life-threatening bleeding risk is high, then you do not give it for 6 months, you give it only for 3 months. If it is very high risk, this is high risk, this is very high risk of life-threatening bleeding, then you must give the dual antiplatelet therapy for at least 1 month. Then ticagrelor as the usual protocol. Now, when you are giving this dual antiplatelet, especially those who are receiving aspirin, proton pump inhibitors must be given. Concomitant use of a proton pump inhibitor is recommended in patients with aspirin, DAPT or OAC therapy who are at high risk of gastrointestinal bleeding. The problem with the proton pump inhibitors, some nephrologists do not like it, saying it is nephrotoxic, but the guideline tells us it is a class 1 indication if the risk of gastrointestinal bleeding is there. So, we will now skip this slide. Now, in patients with chronic coronary syndromes, optical medical therapy is the key for reducing symptoms, halting the progression of atherosclerosis, preventing atherosclerotic myocardial infarct, revascularization. Now, myocardial revascularization plays a central role in the management of CCS on top of medical therapy, but always as an adjunct to medical therapy without supplanting it for symptomatic relief and maybe improvement in the prognosis. Now, all the trials have shown that stenting alone, PCI alone, does not reduce it. The MACE and the mortality. FAME2, the ORBITA trial, which is very small, various numerous, and 2019, I do not know how many have read it, the ischemia trial is now out. The ischemia trial is the latest trial comparing high risk coronary artery disease patients divided into 2 groups, 52,000 patients I believe, into the invasive arm and the non-invasive arm where pure medical therapy was used, very much like the COURAGE trial, but this is more advanced, and the ischemia study shows there is no benefit. There is no benefit, except that in the relief of symptoms is of course superior when you do the revascularization, and there seems to be a slight reduction in the non-fatal myocardial infarction in the first 2 years. So, the ischemia study confirms what the ESC guideline has been saying. I would recommend that this is not published yet in a journal, peer-reviewed journal. It is presented at the American College regional meetings, and therefore we know the results, and it is under very great scrutiny. Now, the 90% diameter stenosis business, it is a problem there. And these new trials findings say that PCI can be safely deferred in patients with stable coronary artery disease, even in those with extensive multivessel involvement and inducible ischemia, provided that intensive, multifaceted medical therapy is instituted and maintained. Medical therapy has to be proper. Now, why do we take this 90%? Because the 60 to 90% plaques are mature, they don't rupture. The younger ones are immature, they are the ones with rupture. And though we have what is called the oculostenotic dilatation reflex, you see an obstruction, you want to dilate it. Though the reflex is there in the interventional cardiologist, and anyone looking at the angiogram report, especially the patients also, it is over 90% that acute coronary syndrome or a myocardium without rupture can occur because of the thrombosis. Now, a very interesting thing is the medical therapy, antiplatelet therapy used in the COURAGE trial. All patients had antiplatelet therapy. All patients had extreme ischemic therapy, and the standards of secondary prevention, aggressive lipid lowering up to LDL 60 to 85, and lifestyle modification with regular exercise was there. FAME 2. So, shall we skip all this? So, when we are going in for medical therapy according to the ESC guidelines, we have 7 arms of therapy. You have to prevent the progression of the existing plaque. You have to induce regression of the existing plaque. You have to prevent de novo plaque formation. If new plaques form, you stabilize the plaque, preventing rupture and fissuring. You prevent platelet thrombus formation. You enhance arteriogenesis, and you reduce the MI size and complications if a MI were to occur if your medical management fails. Note that a verb has been used to define the targets, so that there is something active to be done to achieve each of these arms of therapy. Now, what is the optimal LDL level that we are talking about? These are very old slides. The minimal luminal diameter seems to be static when we get the LDL to 70 in the secondary prevention trials. If you go to the primary prevention trials, the same can be achieved when the LDL is 55, the coronary heart disease events. Now, if you go into the events in the secondary prevention, it has to come to about 30. That is why the Odyssey trial using the evacuumab went up to 30 or so LDL, below 60, because of the extrapolation that you get from this. Now, remember that though we give medical therapy, not all patients will regress. There are regressors, there are progressors, there are mixed responders and non-responders. And we had a whole gamut of these people in one basket, and we sometimes have very controversial results. Now, we will skip all this because we have no time. And statins are recommended for all patients. If the patient's goal is not achieved with maximum tolerated dose of statin, you must add ezetimibe. If that also does not work, to come to the goal, then you use the PCSK9 inhibitor, though it is very costly. It is now come into the guideline. ACE inhibitors recommended if a patient has other conditions such as heart failure, hypertension or diabetes. But if the patient has very high risk of cardiovascular events, even without hypertension, failure, or diabetes, a lipid soluble ACE inhibitor, perindopril or ramipril, is recommended for endothelial health, and therefore this becomes a two-way recommendation even in the absence of the classical indications for ACE inhibitors. Beta blockers, patients with LV dysfunction and systolic heart failure, no doubt we have to use it. But if the patient has a previous STEMI, long-term oral therapy with a beta blocker should be considered for secondary prevention of a second myocardial infarction. Microvascular angina, very difficult to prove, but if you suspect vasospastic angina, a Holter ambulatory ECG is the best one to see the ST segment changes. Now, if the patient doesn't have any symptoms at all, asymptomatic, should we go screening for coronary artery disease? The total risk estimation should be done for anyone over the age of 40 or below 50 in the second guideline with lesser level of evidence, and then depending on your risk score, you have to investigate these patients. The calcium score is of no value unless the risk is very low. If very high risk, calcium score has no value. You have to maintain your blood pressures, and the blood pressures that are given for the office is less than 40 and less than 90. Though the guideline says 120 to 130, this is on the ambulatory blood pressure feeling. And remember that in the elderly patients, do not reduce the blood pressure to very high levels, very low levels. Anything less than 160 to 90 is acceptable in these patients. Now, diabetes mellitus recommendations are important. Blood pressure, LDL and HbA1c, you must bring it down to your targets. You have to give a ACE inhibitor for event prevention. It is a high risk state, and ACE inhibitors are given for endothelial health. The Ramipil and the Perinropil for reduction of event prevention in diabetics. This is a recommendation. Of course, now you have to use empagliflozin, canagliflozin, dapagliflozin recommended in patients with diabetes and CVD. That is class 1. All patients must receive this. Or the glucagon-like peptide 1 receptor agonist, the liraglutide or the semaglutide. Of course, these are injectable. The glyphosins are oral. The glutides are injectable, except the semaglutide, which has now come in an oral form. Whether it is available here, I do not know, but it is important. Patients with kidney disease, don't do unnecessary contrast injections. It will come to problems for these patients. And in the elderly, the drug-eluting steroids are still recommended, though we have to give long-term antiplatelet agents. Hormone replacement is not recommended in the postmenopausal women. That recommendation stands. And my final slide, if all this fails, external counterpulsation is there. The ECC external counterpulsation, which we do, enhanced external counterpulsation, EECP, the external corporal shock wave, the coronary sinus constriction. You constrict the coronary sinus, then the blood flow from the coronary arteries do not flow into the coronary sinus, and the coronary perfusion remains better. The neuromodulation, gene therapy, and the autologous therapy all are experimental, except the enhanced external counterpulsation, which will be useful for symptomatic relief only, though prognostic benefit has not been demonstrated. I don't know, I have taken up too much time, but thank you very much, and that is a synopsis of chronic coronary syndrome management. Thank you.
Thank you for Dr. Ekanayaka for the excellent lecture. I think he cleared up our mind. When the primary PCI patient going home, we start ACE inhibitor, beta blocker, irrespective of their blood pressure. And we give dual antiplatelet. Always question when they admit whether to stop clopidogrel. I think new guideline has recommend continuation of the dual antiplatelet, irrespective of their blood pressure, starting ACE inhibitors and giving high dose statin. Keep the LDL lower the better, up to 30 milligram LDL level. So the next lecture is delivering by Dr. Stanley Amarasekara. He is covering up the acute coronary syndrome. Dr. Stanley Amarasekara is a senior consultant cardiologist who does lot of intervention in the country. Had pioneering like masters in PTMC, chronic coronary syndrome, chronic total occlusions, and over to you, sir.
This is one of the CME organized by Sri Lanka Heart Association with the collaboration of Zydus Kerala, and I must thank the team of the Zydus Kerala for organizing this meeting with the SLHA, and also to address on behalf of Sri Lanka Heart Association, Dr.Ruvan Ekanayaka, our patron of the Sri Lanka Heart Association, and the council members, the office bearers, and the ladies and gentlemen. And today we have planned this webinar with coronary syndromes. We have just finished the chronic coronary syndrome, and now we are coming to the acute coronary syndromes. I hope you will not sleep now because you have taken already much of your time with the dinner. And there was a small mistake, but whatever I have saved in the Mac computer has not worked here, so I had to use the previous presentation, which has the same thing, but a slightly different modified one. I was bringing it today, but I couldn't make it. So coming to acute coronary syndrome updates, as we know that the coronary syndromes causing acute events have been reducing in the West and in the Europe, but in Asia, there is a paradoxical small rise in these events. So therefore, I think we should be updated to see what's going on. I'll be hoping to speak on the acute coronary syndrome includes a spectrum of clinical syndromes, which is all ischemic chest pains, unstable angina, from unstable angina, non-ST elevation MI to ST elevation MI. There has been more overlaps with the previous lecture, so I think my work is easier because of the Dr. Ekanayaka's talk. And I'll be talking on pathophysiology, history, the diagnosis, the risk stratification, and the treatment of acute coronary syndromes. If you look at the plaque characteristics of vulnerability, which is very important, all of us have plaques, but if you don't get ruptured, if those plaques, you will not have any acute coronary events. What happens with the plaque vulnerability comes up, there's increasing monocytes accumulation, polymorphonucleoleucocytes, matrix metalloproteinases, and the absence of smooth muscle cells, and the fibrous cap reduces to less than 65 microns, they say, and there is a large necrotic lipid core with neovascularization prior to the rupture. And if you see that we have already seen this slide, there is categories of rupture prone. You have the laser pen? All right. You have the normal coronary artery across, and with the rupture prone vulnerability with a large core infiltrated with macrophages and neutrophils, and this is partially ruptured and healing, and this is ulcerated one. And the most of these vulnerable plaques, they rupture with 75%, and also erosions occur in about 25% of these patients. And what is associated with this plaque rupture is the exertion, sudden exertion, sexual activity, losing temper, mental stress, using tobacco, air pollutions, and also different stressors and infections. And this is an interesting slide. I put it because in the circulation 1986, Davis MJ has reported that patients with unstable angina who have died of ventricular fibrillation found to have plugged capillaries with platelets. So the microembolization is the cause of this death following acute coronary syndrome. And as you see that the incidence of acute coronary syndromes and the mortality rates are improving over the last 5 decades, starting from 1954 with the open heart procedures, then coming into coronary angioplasty by Andrew Goodsing by 1979, and with the implantable defibrillators coming up in 1980, and then introduction of streptokinase or lytics, and primary PCI has shown to be superior to the lytics in 1993, and then following that several development of new medications have improved the outcome of acute coronary syndromes. Then, as you know, that evaluation of guidelines going on every 2 to 4 years, and we have now come to about 16, 18 of ESC guidelines of acute coronary syndromes, which I have to modify here. So if you don't get updated, you are behind the management of regimes. I have taken the statistics of the United States just to show you the proportion of ST elevation MI in acute coronary syndromes. It's about 1/5 of the patients are coming to us as ST elevation MI. The 4/5 of the patients belong to unstable angina and non-ST elevation MI. I don't see a big difference in our situation, I hope. Now let's getting into the presentation of MI. To memorize you, the sudden onset of severe retrosternal chest pain radiated to the left arm and jaw with pressure squeezing, tightening sensation lasting more than 20 to 30 minutes, with sweating, with shortness of breath without autonomic features, and a substernal area, precordium, epigastrium, radiation to left arm, jaw and neck and shoulders. I don't want to say anything more because we have already listened to these histories. And as you know that the ESC has given all these A and B, C recommendations based on the clinical evidence. And recommendations also, similarly what you should remember is the class 3 recommendation cause more harms, should not follow that. And coming to the ESC, the triaging of these patients, initial assessment of patients with the presentation with the history, and secondly, within as soon as the patient is reached, ECG is the most important investigation to do. Thirdly, you must go for a cardiac biomarker. Fourthly, you must make the diagnosis. And these are now, there are HS troponins have come up. There are different techniques of HS troponin, so you must go to their references and find out the upper, more than the 99th percentile of upper reference levels. You have 0 to 3, that is from the first medical contact or the history of chest pain to 3 hours or to 1 hour. And then the standard troponin is after 6 hours, HS troponin is before that, and you must work the diagnosis depending on the value. And basically it is like this 1 hour protocol of more than 5 times rule in the patient, and less than 3 times rule out the patient. Between 5 and 3 is observed and repeat the test in about 2 hours, another 2 hours to make it 3 hours. And Dimension Vista is believed that it's being practiced in National Hospital, Colombo, and different other places they practice the Architect. I'm not sure about the other technique, but these are the techniques available, so you must refer this, it's available. So what has been achieved by taking the HS troponin is the higher negative predictive value for acute myocardial infarction, reduce the troponin blind interval, which is we have been using, waiting for the standard troponin for 6 hours, which you don't have to do, and results in increasing diagnosis of 4% absolute and a 20% relative increase in the detection of MI, and associated with twofold increase in the detection of type 2 myocardial infarctions, and the number of unstable anginas have reduced because of this. And we don't have that situation, but if you look at the West, they have to the hospitals have to get their budgets allocated, but if the troponin is positive, it becomes an unnecessary MI and the budget is increased rather than the unstable angina, so the budget difference. So that is happening in West, so these are the changes. Then one must also remember that the acute coronary syndromes can mimic all the differential diagnosis of pain coming from cardiac, pulmonary, vascular, gastrointestinal, orthopedic and other causes. Let's look at the risk stratification. Then you come to the risk stratification. Based on the short-term ischemic bleeding risk stratification combined to the clinical history, this is class 1 recommendation, and a 12-lead ECG should be done within 10 minutes. And additional lead should be done if the 10 minutes ECG doesn't show changes, which is to rule out a right ventricular infarct or a posterior infarction, and to establish the risk score. And to measure the cardiac troponins within 60 minutes, rapid rule out protocol or 0 to 3, or rapid rule out and rule in at 1 hour and 3 hours later. And you must, once having gone through the patient, you have done the ECG, you have taken the history, the next episode is to send the blood for biomarkers and then the risk stratification. which is important. Why it is important, the risk stratification? Because based on the risk stratification, your treatment modality is different. So you need to identify very high risk patients, intermediate risk patients, and low risk patients. And the very high risk patients are the ones who have fatal arrhythmias, cardiac arrest, non-responding to medical management in cardiogenic shock, and so on. The high risk category is the people who have the troponin rise and fall, and also a dynamic changes with the GRACE risk score, that is global residual association. I will come back to this risk score. The risk score is you can calculate it online, and you get the risk value of between 109 to 140 is a high risk, less than 109 is low risk. Now, having done the risk stratification, what is important is if you have a very high risk patient, it is similar to ST elevation myocardial infarction, you must attend to that patient for an intervention very early, less than 2 hours. But if the patient is in high risk, the patient can have about 24 hours time to intervene. And if the patient is in intermediate risk, that patient has 3 days to attend. And if the patient is low risk, you can subject the patient to exercise ECG and discharge the patient on the same day. So therefore, the risk stratification is very important once you have listened to the patient and having done the ECG. And to reduce the bleeding, this is also very important. Now, when as same as coronary artery disease risk factors and other factors, one has to consider the bleeding risk of the patient, because that has an increased mortality rate in these patients while you are treating. And this is a flow chart given for management of patients with in different areas of where the drugs are being used, anticoagulant drugs and antiplatelet drugs in different places, how it works. All these are given in this picture. Now I'll be taking one separately all these. Now we have listened to the treatment of aspirin, ticagrelor and prasugrel and clopidogrel, and but they all have class 1 recommendation. What is important is, but the clopidogrel, there is 300 or 600 milligrams loading doses. I would specify this. If the patient goes for PCI, you must load for 600. If the patient goes for fibrinolytic, you must load it with 300. That's the difference between 300 and 600. Let's talk about that. Then adding the mineralocorticoids, keeping the blood pressure, and rehabilitation program following ACS, and the LDL cholesterol. If the cholesterol is even after the maximum dose, tolerated dose of statins, and if the LDL is over 70, you must add a different drug to bring it down. Coming back to the risk factors, what is new is that in non-modifiable is there's nothing new. Modifiable traditional risk factors, nothing new. Then the following other risk factors are taken up as additional ones. The psychological stress, alcohol, excess alcohol, dietary patterns, lack of exercises, and obesity. Coming to the consequences of plaque erosion and rupture, you get different kinds of plaque involvement. This is the erosion with covered platelets. Here is a plaque rupture with enlargement of the platelet plaque, and here you get the distal embolization, and here you get a complete occlusion. And but this is a platelet to memorize you how many receptors in the platelet. You get the PAR1 receptor to P2Y, P212, and all these thrombin, ADP, thromboxane, epinephrine, serotonin, and collagen can attach to these platelets, can stimulate finally the 2B3A receptor, which binds to the fibrin and also cause the adherence of the next platelets coming up in. So this is important to remember that your treatment can be adjusted on this. And once the platelet is stimulated, it produces degranulation. So the activation is mainly happening through the epinephrine and collagen, serotonin, thrombin, and 1 milligram factor from the tissues. And then once it degranulates, it crosses platelet agonist, pro-inflammatory factors, and also prothrombotic factors. Yeah, this is just to remind you the undergraduate level of your coagulation cascade. Why I put this slide is, the intrinsic pathway and the extrinsic pathway goes into the common pathway of factor 10, activate into factor 10A, finally activates the thrombin to fibrinogen to fibrin. Out of this, all these factors in this coagulation cascade, what is important is the thrombin. The thrombin can activate the common pathway, thrombin can activate the intrinsic pathway, the thrombin can activate the fibrinogen to fibrin, and also fibrin can be made cross-linked stable fibrin. So thrombin is the culprit in acute coronary syndromes. If you block thrombin, if you take off thrombin, the acute coronary syndrome, 50% of the acute coronary syndrome is off. So that is why I put this slide. And see the activation of platelets, the activation goes into aggregation and then adhesion, which is a chain event. And now you come to a complete thrombus formation with the activation of the platelets, activation of the coagulation cascade with the wall rupture, with the collagen exposure and the tissue exposure, tissue factors producing the prothrombin into thrombin, thrombin joining with the fibrin along with the platelets, which produces a complete clot. The mainstay of the treatment comes up from the aspirin, which blocks the cyclooxygenase, preventing the arachidonic acid to produce thromboxane. So the place of aspirin is very important in prevention of acute coronary syndromes. And this is the benefit of aspirin in prior MI, acute MI, and prior stroke and unstable angina. All have shown the aspirin is more beneficial than anything else. Coming back to thrombolytics, you get this old-fashioned streptokinase. Now we have got the retiplase, altiplase, and the mutant altiplase of tenecteplase. The myocardial infarction is the rapid development of myocardial necrosis, death of a part of the heart muscle due to sudden loss of its blood supply. And coming to the ST elevation myocardial infarction, once the diagnosis is done, if the patient going into PCI facility, you must straight away transfer the patient. If the patient does not have facility, then you go into the thrombolytics. You must remember the contraindications of fibrinolytics, absolute ones and the relative ones. Very important to remember the relative ones because you can bring down the blood pressure and you can watch the patient giving the fibrinolytic rather than denying the patient on any fibrinolytic on these patients. And these are the doses of fibrinolytics. And hyperglycemia is also important. You should not make the patient hypoglycemic. That is very important in ACS. But you can manage the patient until up to about 180 to 200. You don't have to rush to give anything seriously in acute coronary syndrome. And reperfusion strategy, if the patient comes to a cath lab facility, the patient should have the wiring. Earlier they said 90 minutes, now they say 60 minutes. It is reduced, not in this chart. And ECG should be done within 10 minutes. And if the patient is not in a cath lab facility, if the patient cannot reach within 120 minutes a cath lab facility, he should have the fibrinolytic within another 10 minutes. So to go to needle time is not 30 minutes, now another 10 minutes. And also, if the patient goes to the cath lab facility from a non-cath lab facility, that patient should have a wire going through within 90 minutes. Right now, it's not door to needle time, balloon time. It's not balloon time is taken off, and it's called wiring time. And this is the MI pathophysiology with total occlusion, which is with ST segment elevation myocardial infarction. And this is a ruptured plaque with a non-occlusive thrombus. You get a non-ST elevation MI. And this is very important because to show this is, I am showing this slide, this is experimental coronary artery occlusion in 3 myocardial regions is defined. And this has 3 zones. If you could identify, the inner zone is the necrotic myocardium, the second zone is the ischemic myocardium, and the outer zone is the normal myocardium. So this ischemic, the necrosis occurs with wavefront phenomena. If you put a stone into a still water, how the water waves going, the similar way the myocardium is necrosed and the time is the muscle, and 3 hours what happens, in 96 hours what happens. So you have to act very fast in case of acute coronary syndrome with ST elevation MI. What are the strategies available? You have primary PCI, administration of fibrinolytics, and after that you intervene the patient, which is called pharmacoinvasive. And the coronary embolization is the next thing that can happen as the patient is delayed with thrombus formation, distal embolization. And distal embolization is happening from the primary thrombus. It goes into block all this, so that you will not have ST segment resolution even after PCI once this has happened and when the thrombus load is high. And the patient may continue to get angina. These are the extracted thrombi. Coming back to thienopyridines, and you have the ticlopidine, clopidogrel, prasugrel, and ticagrelor. Now we are no longer using the ticlopidine because of the side effects and the low efficacy, and the clopidogrel, prasugrel, and ticagrelor, and we will explain this in further. The clopidogrel has 2 steps. It's a prodrug. It has a 2 steps oxidation prior to come into the action of P2Y12 receptor, whereas the prasugrel has 1 step and ticagrelor doesn't have it. So ticagrelor works very fast and active. What is important to know this oxidation part, one is this CYP253A, which is an enzyme and which competes with some of the PPIs. So the PPIs, when you are giving PPI, sometimes the effects of clopidogrel can come down. Second thing is that we have already heard last time when Dr. Ekanayaka published a study on clopidogrel resistance, which is surprisingly in Sri Lankans have a higher value than most of the other Western countries. And therefore, if a patient is on dual antiplatelet coming back with the ACS, one must think of changing the clopidogrel to a better drug. And this is the cangrelor IV preparation of the ticagrelor, which acts very fast, and it's 100% platelet inhibition and very quick and short half-life. And this is being recommended now in the cath labs, people who have not been loaded up previously. And every patient, all these thienopyridines have to be loaded. Ideally, they should be loaded 6 hours before in clopidogrel. You see this thienopyridines in PCI cases, 50% platelet inhibition should be achieved in ACS patients. Therefore, you must load if the patient is going for PCI with 600 milligrams, and the 300 milligram maximum you can get it in 40, which is in 12 hours. So soon after the procedure, you can go into a thrombosis if you don't know this, and you can sort of at that until you cover that with a different drug. Whereas the prasugrel and ticagrelor, the action is very fast. That's the main thing that you got to remember, and they are less affected by genetic polymorphism. So therefore, if the patient comes in recurrent coronary, acute coronary syndromes, that patient should be shifted to these drugs. The prasugrel and ticagrelor has been shown to be effective in TIMI 38 primary PCI trial, and also a Plato primary PCI trial in stent thrombosis. It reduces stent thrombosis, both these drugs, more than the clopidogrel. And also, it reduces the cardiovascular deaths in primary endpoints more than the clopidogrel. And this effect is long-standing. It is not a short-term effect. So the effects of prasugrel and ticagrelor is superior to clopidogrel, but that lasts longer. But also that this trial has observed more bleeds in the prasugrel and ticagrelor group. So therefore, one must select the less bleeding complication patients for selecting the long-term benefit of these 2 drugs. Coming back to antithrombines, the 3 or 4 antithrombines what we have now is unfractionated heparin, fondaparinux, low molecular weight heparin, bioluridine. And out of this, the heparin benefit everyone knows. It has been shown in meta-analysis that heparin plus aspirin is superior to aspirin alone. And then the fondaparinux, what is important in the fondaparinux is in OSI 6 trial, this drug showed catheter-induced thrombosis. Therefore, if you think of PCI, fondaparinux should be avoided. But it's a very good drug for medical management patients because it has single dose, compliance is good, and it's acting with patients who are not going for catheter procedures. And this is bivalidine. What is important in bivalidine is that it acts on the thrombin of different phases: fluid phase thrombin, clot bound thrombin, thrombin mediated aggregation, platelet aggregation. And this is very important drug because it works for HIT syndromes and also causes less bleeding. Now I have put up this slide to show that the number of different combinations that one can achieve with all these 4 or 5 items. Now see the anticoagulants of unfractionated low molecular fondaparinux and bivalidine, antiplatelets of aspirin to prasugrel, ticagrelor and clopidogrel, IV antiplatelets of eptifibatide and irofeban, catheter procedures, either you do it invasive early, late or never. If you get this, out of all these 16 categories, you can achieve about more than 100 combinations. So unless you are updated and you select the patient, which patient has to go into this, which combination, you are out of your mind. And what is happening? Right. Now these are the factors that you must consider selecting these items. Now see the severe renal insufficiency, you must go into unfractionated heparin and avoid low molecular heparin. And increased bleeding risk, you must select the bivalidine. And thrombocytopenia, you must select the bivalidine as the best drug, and the worst drug is the unfractionated heparin. And early cath strategy, you must avoid the fondaparinux. That's the most important thing. Okay, now coming back to the universal definition of this is actually the 4th universal definition of myocardial infarction, and one must demonstrate rise and fall of cardiac biomarker elevation troponin above 99% upper reference level with myocardial ischemia. In the setting of myocardial ischemia, that is very important. Just going troponin is not going to be the definition of myocardial infarction. So myocardial in the setting of ischemia, and either one of the following: typical ischemic chest pain, development of new ECG changes, development of regional wall motion abnormalities. If you find all this, then it is type 1. Then the demonstration of coronary thrombosis in a coronary angiogram or an autopsy, sudden cardiac death with suggestive ECG changes where the biomarkers could not be performed, PCI related biomarker elevation more than 5 times, CABG related biomarker elevation more than 10 times. The HS troponin now available in, but I think we have discussed this. The types of myocardial infarctions: type 1 is the plaque ulceration, fissure, rupture, dissection causing coronary thrombosis. The type 2 is there's a mismatch of oxygen supply and demand, where you get the patient get tachycardia, hypotension or anemia, you can get type 2. Then the type 3 is the sudden cardiac death with ECG changes or coronary thrombosis. Type 4, PCI related MI, biomarker elevation within 48 hours, not 3 times, it's 5 times. I'm sorry, this is 5 times, because the previous guidelines said 3 times, now it's 5 times, the latest ones. And type 4B is the stent thrombosis, C is the restenosis, right? And type 5 is the MI following CABG within 48 hours, biomarker going up 10 times or more. And the decision regarding reperfusion strategy: primary PCI is superior to lytics, pharmacoinvasive strategy, which is probably the best for us in our setup. And ECG should be done within 10 minutes, loading doses are given, and then you must think of antithrombotics and lytics. Now this is to show the meta-analysis of randomized 23 trials to show that the primary PCI is superior to lytics. Even events at 4 to 6 weeks. All these yellow bars are PCI and lysis in red. And and this is to show that it's not only just primary PCI is superior, that what is important is to achieve the TIMI3 flow. If the TIMI3 flow is not achieved, that your mortality is still high. You see that GUSTO-RTPA, GUSTO-2B trials have shown a 6% mortality rate, which is TNK TPA and a TPA. and the stent PAMI and PAMI trials have shown better TIMI flow. And why the thrombolytics have failed? They have incomplete reperfusion, platelet activation following thrombolytics, recurrent ischemia and reocclusion. Reinfarction is the most important thing, and bleeding complications. The message from thrombolytic guru is that you must do within very early, within the first 1 hour you must give the fibrinolytic, and you have the biggest benefit, absolute benefit coming up. After about 6 hours your benefit is waned off. And this is to show the PTCA and the thrombolytics causing the TIMI3 flow and the reperfusion, and what you get in the drugs, the most maximum that you can get is 60 to 62%, whereas the PTCA with stenting studies have shown more than 90% reperfusion. And now this is to show the reperfusion strategies for ST elevation MI, transfer PCI versus fibrinolysis. Now when the patients arrive to a non-cath facility, whether you give fibrinolytics or transfer the patient. Now the transferred patients, are all these studies have shown, are superior to the patients who have had on-site fibrinolysis. And this is to show the standard method of treatment after the fibrinolysis versus routine pharmacoinvasive procedure. This is called transfer MI trial. So you don't wait, you don't look for the reperfusion or non-reperfusion, you straight away transfer the patient, which has more benefit. That's a transfer MI trial has confirmed. And this is the dose of the aspirin, but I don't think that we should discuss this, everyone knows about this. And the ideal dose is, when you try to go into the 300, the over 300 you get more bleeding, and you get less than 150, your benefit is less. So you must select between 75 to 150 dosage of aspirin in these patients. What is your goal in acute ST elevation MI is to send the patient for definite revascularization after facilitation. Now everyone should concentrate on a bleeding complication also, because these patients should not go into bleeding complications because that carries a mortality. Now this is impact of hospital bleeding in acute coronary syndromes. 34,146 patients in OASIS trial 1 and 2 cure trial, as say major bleeding causes increased mortality, and this is in the first 30 days. Now let's see what has happened in the next 1 year. The people who bleed will have mortality continues to rise even after 30 days. So your groin punctures, your bleeding due to pericardial effusions or bleeding due to any other cause will carry a higher mortality. So you have to be careful with this. And what is best in this reducing mortality in bleeding complications is the bivalirudin alone in combination with other two, and this is shown in Acute trial. Now in summary, universal definition of MI and types of MI are very useful in consideration of different setting of presentation of MIs in acute coronary syndromes. The clinical history plays a major role in diagnosis of acute coronary syndromes and choice of treatment. The risk stratification is very important in non-ST elevation MI to decide on the timing of the invasive treatment. HS troponin is used as an early investigation to rule out and rule in acute coronary syndromes in emergency. Unfractionated heparin and low molecular to be used as antithrombotics in acute coronary syndromes with MI, and now the unfractionated heparin has got green, and low molecular heparin has got yellow, and the unfractionated heparin has got orange, which is class 2B. in the new guidelines. And the primary PCI is superior to lytics in ST elevation MI. Time delay should be minimized to 10 minutes once a diagnosis is made with the ECG. Aspirin, ticagrelor and prasugrel are the first choices of drugs if the for loading of before PCI. If they are not available, then your option is to go for clopidogrel, but make sure that you don't give the ticagrelor and prasugrel to wrong patient and more bleeding complications. Facilitation with lytics and 2B3A, no significant benefit in primary PCI. The on-site 2B3A IVCP and primary PCI beneficial in only selected patients, not in routinely. Following lytics, routine PCI should be encouraged in ST elevation MI irrespective of the reperfusion results. The routine thrombus aspiration is no longer recommended in the latest guidelines. Bivalodine is useful in high-risk patients with bleeding tendencies, but which is taken to from class 1 recommendation to class 2 recommendation. Major bleeding and TIMI3 flow influence your mortality in the short term and in the long term. Fondopharynx to be avoided in catheter procedures and the patients who are waiting for PCI. These in primary PCI is superior to bare metal stents in the latest. Yeah. Thank you very much.
Questions? We have, I think Dr. Disna has brought some questions. You got any? No, she doesn't have. Okay. No, we don't have questions. I will invite Dr. Ruvan Ekanayaka and Dr. Stanley to come forward. And I think this symposium is mainly for medical officers who work in National Heart Center, our cardiologist.
Latest guidelines of ACS, that is 2018, the unfractionated heparin has become orange and the low molecular heparin has become yellow. They are class 2, both class 2. And in ACS, low molecular heparin has got superior benefit to the unfractionated heparin.
So, but that is well known?
No, earlier they were equal prior to this.
I have one question from Dr. Stanley Amarasekara. When a patient transferred for rescue PCI, imagine patient had got a thrombolysis from peripheral hospital, had given clopidogrel 300 or 300 milligram and aspirin 300 milligram, patient coming to primary PCI. How do you load ticagrelor or prasugrel?
irrespective of the clopidogrel, you have to load it again with whatever you are going to use. But if the patient has had fibrinolytics, you got to be careful even if you have loaded with a new drug. So for you to get the maximum benefit of the new drug like ticagrelor or prasugrel, you must give the loading doses, because otherwise you will not achieve the 50% reduction. But if the patient has reached you after 6 hours, after having 600 milligrams of clopidogrel from outside, then that means that patient has already got 50% inhibition of platelets complete. So if the patient is in a very short duration, then definitely your bleeding tendency is less. But you must load with the, irrespective of the previous loading, you must load with again with the new drug.
I think there's a question coming from Dr. Nishan Vas from Jaffna.
He's from UK.
It's from UK. He mentioned the lecture is excellent. And in which type of patient will you advise on upstream 2B3A, sir?
Yeah, these upstream of 2B3A inhibitors should be given to selected patients. If the operator decides that the patient has more thrombotic burden, and then you should do is particularly with graft thrombosis and in ectatic vessels, and patients whom you think that the thrombosis is causing the slow flow or no reflow, then you can try on this, but not in routinely.
Thank you very much. I think I have one question for Dr. Ruvan Ekanayaka. Sir, when we have done a primary PCI, given a ticagrelor, patient is on ticagrelor, now almost is come to the chronic coronary syndrome. So after 1 year, patient is coming and telling, I can't afford anymore to continue because it's a cost effective. And how do you switch over to clopidogrel, sir? So are you going to load with clopidogrel, or are you going, what is the recommendation, sir?
Switching over loading is not necessary. If it is after 1 year, then you can immediately start on the maintenance dose and continue. The maintenance dose itself can be started. Before that, if you are doing it, even then the patient is still anticoagulated. Remember that even if you are on ticagrelor and you are starting on clopidogrel, once you stop the ticagrelor, the action will be there for will be a minimum of 3 days. So it is anyway inhibited. So you are going to give clopidogrel to this patient, and the action of the clopidogrel will start, because it's a prodrug, within 24 hours. Therefore, the loading is not necessary in this type of patient, because this is not acute coronary syndrome.
Yeah, can I ask a question, you sir? Now, those days, the intimal medial thickness, ankle brachial index, and the calcium levels scoring and those things. What are your comments on those measurements on assessing the patient with chronic coronary syndromes?
Those three are mentioned in the ESC, though I didn't mention it in the slide when I discussed it. The carotid intimal thickness, the ankle brachial ABI, and also the calcium scoring help to risk stratify, but they are not in the risk stratification scores. So they are not to be used for diagnostic purposes. You cannot use this as a surrogate imaging. Now, for example, the carotid atherosclerosis cannot be taken as a surrogate for coronary atherosclerosis. But if it is there, it means that you are susceptible, but it does not. It has not been included in the coronary risk evaluation. This is mentioned in the ESC guidelines of 2019, and they are said not to be used for diagnostic purposes.
Are there any questions from the audience? Anything from Jaffna or Gaul? I think Indika got a question.
I have a question, sir. Now, this is regarding revascularization in chronic coronary syndrome. Now, chronic coronary syndrome, revascularization, what they say is that one thing is for prognostic benefit, and there's then other component is there for symptomatic benefit. Obviously, symptomatic benefit, drug reduction and quality of life improvement are there. But this is regarding prognostic benefit. What they say is left benefit is 50%. And if the proximal LAD is 50% and there's demonstrable ischemia, then revascularization should be considered. And if demonstrable ischemia is not there, then only comes the FFR or invasive evaluation of physiological functions. But is your idea about that's a little controversial because
That is
FFR
correct.
is not available for us. So
That is correct. That is why this in chronic coronary syndromes we put up the slide on the high risk for events. And your left main, the triple vessel disease, the proximal LAD, 3 more than 16 of the segments, etc. all this coming. In which case revascularization helps. But now it is again controversial with the new ischemia study. The ischemia trial used high risk patients, and with the intensive medical therapy the risk seems to be mitigated. The important fact that is coming out of the ischemia trial is that the amount of acute coronary syndromes occurring in this chronic background seems to be less now than what they anticipated. And they are asking why is it less? That is because of the current therapy. The current therapy is stabilizing the patients so that they are more chronically going on without getting a ischemic deterioration. Acute deterioration. So therefore the whole argument is now opened up again with the new ischemia trial. But I think the ESC guidelines where they showed the high risk for events and said that in this particular group of patients considering revascularization might be helpful would be a useful rule of thumb.
again, when it comes to 50 to 70% or rather 90% lesions, now there's a category of people that they are symptomatic, and if you do the exercise ECG, that is again positive. So that means, I mean, there is a kind of demonstrable ischemia. So in that category, will it benefit? I mean, 50 to 90%
It
lesion.
will certainly benefit for
Not the prognosis, it is a
symptomatic
symptomatic benefit.
for symptomatic benefit. There is no controversy about that. For symptomatic benefit, opening of that artery will be of benefit. But whether we are going to have prognostic benefit is the problem.
I think that your question can be answered if you know the plaque is vulnerable or not. If you are dealing with a vulnerable plaque, with whatever you are got so far, then you must intervene to that plaque.
So when I was saying that it is less than 65 microns, will help, is it?
You must go for a proper scanning of the plaque to see the capsule of the plaque. And if it is less than 65 microns and it attracts your isotopes when you are checking it and demonstrates inflammatory cells, you must stent that.
It might be cheaper to send it and finish.
So, shall I summarize the lecture today?
Thank you.
So, the ischemic heart disease is divided into acute and chronic coronary syndrome. Acute coronary syndrome has 3 types: STEMI, non-STEMI, and unstable angina. Chronic coronary syndrome has 6 varieties, which included already stented, bypass within 1 year, more than 1 year, or diagnostic test just identify the ischemic heart disease, or vasospasm angina. So, looking at the guidelines, we know where to reduce the LDL. If the cholesterol seen a lipid profile, don't stop atorvastatin. Please continue the high dose. Keep the LDL 30 milligram. You can go up to 30. And the blood pressure level, you all know, 120/70. If it is elderly, 140/80. So guideline recommended ACE inhibitors, beta blockers, statins, and giving ticagrelor or prestigrel. Don't discourage. Please do continue that because it's benefit than clopidogrel. And how to bridge from ticagrelor to clopidogrel, or giving how do you load at the cath labs. And I think this is the summary. And now because of the development of the high dose statin, all the medication, guideline directed medication has reduced the event. And never underestimate the power of the medical management. Even though you have think that the intervention is the always best, both goes hand by hand. And if it is acute coronary syndrome, intervention is best. If it is a chronic coronary syndrome, I think medical management is the best. And still we don't know where to look for the best way of assessing the plaque. And there are many tests, newly occurring tests are coming on, which is not, I think, cost effective for our country. And for doing, we have done 20,000 cases last year, so in NHSL, and some people have not come out to take their even reports. And we feel not adamant to treatment and lot of losses, not coming up to follow-ups. If you're looking at the report collecting room, more than 30% of the reports are still there and not coming to even take and see these. And we need some validation for our country, whether whatever we are doing is correct or not. Acute coronary syndrome, no doubt, it is there. But some chronic stable angina patient which come to cath lab having 3-4 stent, but even they are not turning out to clinic and not adamant to treatment, we are wasting of our money. And I think it's only symptomatic benefit according to the guidelines. So please, and we are going for I think as an HSL, we're thinking of having a validation people who come into cath labs. And thank you all the medical officers coming to this evening, spending your time with us. And thank you very much, Dr.Ruvan Ekanayaka and Dr. Stanley Amarasekara. I think there are more questions coming from other areas. I will invite Zydus people to come forward, yeah, for the vote of thanks.
Good evening, doctors. Thank you very much. This is our first webinar for the cardiac segment. Actually, we have been streamed 3 places simultaneously, Jaffna and Gaul. And I think we have about 200 viewers at the moment. And we like to transform from continuous medical education to continuous webinar education. So this is the initiative. And thank you very much for participating for this event. And we look forward to do more webinars. Thank you very much for participating for this event. Thanks.
Night is yours now.